take this opportunity to thank the Morehouse School of Medicine African American Behavioral Center of Excellence. You do a phenomenal job. You provide services that are very, very important to the African American community, and you've also opened the door for training, education, and technical assistance for the LGBT community. I just want to say thank you for that. I want to thank Dawn, who's just been a tireless leader, and she's the director of the center. Corey, you've just been phenomenal in the support that you provide as technical assistance coordinator. And Kanisha, I don't know what I would do without you. She's the TTS person, and I work with her in a variety of different venues, but thank you so much. And Pamela, I don't know if you're on, but thank you for setting up the meetings and providing our calendar invites as the administrative assistants. So that's the Morehouse School of Medicine African American Behavioral Health Center of Excellence. And so we talked a little bit back, myself and Dawn, as to what the center can do to provide information, education, support, those kinds of things, not just for the African American community, but also for the same gender loving community as well. And one of the things that we said that we would do is, rather than just coming up with, we want to know what it is that you feel are important topics for us to discuss as we begin programming at Morehouse, as we begin deciding what kinds of educational programs we're going to provide for the community. But nevertheless, we have a commitment to the LGBT community to provide this services. And hence comes today's presentation, Can We Talk? Issues and Trends in the Black Same Gender Loving Community. Before we move forward, just a little bit about myself. I'm an advanced implementation specialist with the Opioid Response Network. I'm also assistant professor at Kennesaw State University part-time, as well as Capella University part-time, so several different hats. So those are my professional kinds of hats that I wear. But most importantly, I'm also an individual who's in long-term recovery. This coming August, actually, next month, we will be celebrating 30 years in recovery, and that's what I'm most proud of. And I'm also proud today, July 13th, being a member of the LGBT community for 69 years. And so, yes, today is my birthday, and I'm thankful for just being here. And so, just in terms of what we're going to cover today, we're going to talk a little bit about bisexuality, talk a little bit about health issues related to trans people. We'll talk a little bit about HIV and AIDS among Black gay men, as well as some economic issues related to HIV services. And finally, we'll talk a little bit about intersectionality and how providers can be more aware and educated about intersectionality as it relates to the LGBT community. So if you're not ready, I suggest you buckle up your seatbelts and get ready, because this is going to be a phenomenal ride. We have a very distinguished panel, and I'll introduce each panel member before they do their presentation. And first in line, the phenomenal, fantastic person. I've known this person for over 25 years. He's been inspirational. He's been a trendsetter. He's been a novelist just in terms of setting up programs. But most importantly, the thing, Craig, that most endears me to you is Second Sunday. And that was, oh my God, about 20 years ago, but it was such a phenomenal support mechanism for Black gay men. And so thank you now, and thank you for the work that you do, Craig. Just a little bit more about Craig. Craig was born in Washington, in Queens, actually, New York, and has lived in Atlanta since 1992. He is founder of Intervisions LLC. He's also co-founder of Southern Unity Movement and the Bayard Rustin Audre Lorde Breakfast. He's a writer who has written extensively on issues or on essential matters for thebody.com, Huffington Post, the Atlanta Voice, Georgia Voice, Paz.com, and the Atlanta Magazine. He's created and or led several HIV prevention and support organizations for Black gay men, again, including the infamous, phenomenal Second Sunday. So without any further ado, Craig, come on down. Let us hear from you. Ladies and gentlemen, Craig Washington.
Thank you, Larry. Thank you for all you do, and thank you for inviting me to be a part of this panel. Also, thank you to Morehouse School of Medicine and the African American Behavioral Health Center of Excellence. It's exciting to share this with just fellow luminaries and the wisdom here. I just want to mention that I was intentional in my introduction, in my bio. I talk about not only being born in Queens, but also being born and raised by Anna and Leon Washington. I'm intentional as a openly Black gay man who's been HIV positive for over 35 years, that I come from someone. I come from a people. And when we talk about how Black gay men are seen, not seen, valued, not valued, appreciated, understood, or not so much, it's important to remember context. We'll go to the first slide. So Black gay men, we hold multiple identities and memberships. And I say Black gay men also recognizing that gay itself is not a universal identifiers. So there are some who identify as same gender loving, or same sex attracted, or men who have sex with men, or don't identify at all in terms of sexual orientation. But certainly there are different identities that we connect with: our racial identity based on sexual orientation, age, where we land on the spectrum of femme and masculinity, and sexual identities and sexual positioning. Those are some of the identities that are carried, as well as being members of larger Black and LGBTQIA and other communities. We have a history, we have tradition, like any people. Certainly, there are luminaries that we see in leadership, from Ella Baker and Bryant. There are writers and tradition that speak to our culture, Zora Neale Hurston, to James Baldwin, to Audre Lorde, to Joseph Beam, who represented a generation of Black gay men that were literally writing and organizing for our lives. From Little Richard to Sylvester to Lil Nas X, we've been here. Our multiple identities draw interlocking oppressions. When we talk about intersectionality, that also represents the ways in which we may be targeted by racism, homophobia, transphobia, femphobia, interlocking, again, forms of oppression. It's also important to just hold up that we sit and we're in Atlanta. And while Atlanta has been long recognized as a Black Mecca, it's also the Black gay Mecca. We have one of the largest Black LGBTQIA populations in the country. Next slide, please. So we have to be recognized not only in terms of our cultural identity, right, but also we're not monolithic. And so it's important, I'm speaking certainly to providers, people that are or will be working with Black gay men, to understand and acknowledge individuality and individual expression. There's no one story around our relationships and experiences with family. It ranges, the quality of those relationships range from loving and supportive and affirming to conditional tolerance, to abuse, rejection, isolation, and physical hostility. We create those friendship circles in Black LGBTQ, and I may sometimes I'll interchange with queer as an umbrella term as well. Black queer community, those friendship circles often serve as family, providing that support often that we might not have gotten in our families of origin. We certainly see that over the years, there's been an increased level of visibility and acceptance. But that does not eradicate or erase the homophobia that still exists, those anti-LGBTQ biases. And sometimes you see that being directed at public figures, or we experience that just, just walking down the street in a city that builds itself too busy to hate. For many of us, walking down the street to a MARTA station is an act of resistance and courage. Next slide. Black gay men do not live single issue lives. That's a reference to actually a quote by Audre Lorde that says there's no such thing as a single issue movement because we don't lead single issue lives. AIDS was such a profound event, ongoing, but certainly in its impact, defining to a large extent Black gay man identity and other, certainly Black trans individuals hit in other populations. But it had such a disproportionate impact on Black gay men. And it also posed a significant response. So I give honor to the Rudy Carnes and the Cedric Gardners and the Tony Childs and the Duncan Teagues, a tradition of resistance and AIDS movement, Black men doing that. I want to start an organization to save my life. That's a nod to Essex Hemphill, who begins his elegiac piece around, again, self-advocacy to save my own life. Stigma and trauma, yes, that was certainly suffered by many, but certainly in terms of, again, Black gay and bisexual men who were, excuse me, stigma, we talk about AIDS stigma. It's important just to note that AIDS stigma is in many ways just a distillation of racism and homophobia and other pre-existing stigmas, and that bore to bear. What it meant was, as such a large impact, it drew resources, so much attention, and it left other needs unmet. Many of us who are working on this, if it were not for the AIDS epidemic, what kinds of work could have been done? What kinds of efforts might have been supported? Next slide. And so we come to this place in this state where there's increased meth use we're seeing that among, again, Black gay men. An issue that was previously, a use that was previously associated with mostly affluent white gay men, now it's more and more common among much less affluent, young Black gay and bisexual men living on less than enough. It's a party drug. Or these are party drugs that are used for sex, and they're so readily accessible. You go on an app, people ask if they want to party, there's all kinds of codes. And so it's readily accessible, and it provides a combination of disinhibition and connection. It's a powerful lure. And what it also provides on the social, emotional tip is a sense of belonging. There were a couple of men that talked about that, what they got out of that, not only the rush of the drug or the sex, but also the connection, however fleeting that was. And that's important for those who are abused and experience rejection in their family. It's about self-medicating that trauma and numbing yourself, which is what, again, people are doing when they're faced with addiction. It also feeds easily into and reinforces other related addictions, that cycling effect. So you have the behavior, you have the morning after, so to speak, in terms of that shame about the behavior and the regret, which may lead, again, to the need to escape, the need to numb that pain and that shame. And so it self-feeds and cycles. There's also racial dynamics that must be addressed. I mentioned the shift in terms of this being primarily a phenomenon among white gay men. There are several accounts of white men who use meth to exploit and use people of color. There are directly, and there's accounts of plantation slavery role play, sexual slavery with meth acting as chain, whip, and reward. Sexualized use of the N-word. This is real, this is happening. So an extreme example of this exploitation is the case of Ed Buck, a well-heeled West Hollywood political donor who was eventually arrested and convicted of killing two Black gay men. It was a white gay man, I think I mentioned that, Jamel Moore and Timothy Dean. Thanks to Jasmine Canick, an amazing journalist and activist who shed light on this and spoke to the racial dynamics, race and class, how Ed Buck preyed on gay men who were HIV positive and unsheltered and addicts. And if they weren't addicted to meth, that he helped them get addicted to meth. And he's the most extreme example, but there are other examples, again, of exploitation and objectification of Black, gay, and bisexual, same gender loving men through this epidemic. Next slide. Thank you. So I'm gonna just, I'm gonna do a quick time check. What's my time like? Okay.
I think about now, you probably have got about 1 more minute left.
Okay, cool. Just wanted to do it quick. I didn't hear cue. Okay, so I will speak to actually Mark, and these are all fictitious names. Mark moved from New York, the New York area, to Atlanta, and found eventually that he moved actually decades ago and engaged in survival sex and sex work. By that point, he had been had experienced just being incarcerated in juvenile detention and just having a hard way to go in terms of childhood and internalized shame around his sexuality, around being poor, around just not having enough. He gets to Atlanta, is working Cypress Street, and eventually, as social media, he spoke with the advent of social media, he spoke to how easy it is to develop online hookups. He also spoke to the pattern of housing people that are addicted, getting vouchers. So if they're unhoused and they're in active addiction, they get vouchers from service providers to stay at these sites like SRO, Savannah Suites, and what have you. And he said that is disturbing because it breeds an exchange again around drug use, sex, addiction. And so people are partying in these spaces that are not supervised and there's no treatment provided. And he says that's happening right in Atlanta. So that's something for us to consider in terms of, again, some of the institutional and structural dynamics driving this. I'll leave, but just I'll close with a couple of intervention pieces of recommendations that were shared. One for providers is, again, to assess readiness, provide safety and resources, including harm reduction resources, condoms, PrEP, clean needles, access to insurance. And this is something that Dr. Nathaniel Curry speaks to. Also, he spoke to what people that are experienced, that actually are meth users, that they talked about for their peers, having a buddy system, deciding how much you use when you dose as practical tips and just recommendations. And I'll close there. Thank you.
Craig, thank you so much. That was just so powerful. And thank you for illuminating the names of many of our heroes in entertainment, as well as politics. Some other ones that I was thinking about when you were naming off our heroes, Raymond Simone, comedian Wanda Sykes, singer Tevin Campbell, Audre Lorde, Janet Mock, director for Pose, and it goes on, Alvin Ailey. These are all our heroes that make the LGBT community so rich. So next.
Goes back to Mom Mabley too. You can put Mom Mabley in there too.
Front and center, yes. And so we're going to go ahead and if you hear sort of like a slight buzzer, that will mean that everybody has 1 minute left. And so we want to try to keep on time so that we make sure that the audience has time to ask questions. Next, we have the phenomenal, the fantastic Malcolm, who is from the organization Thrive. And Thrive is a 501c agency that provides support and linkages to culturally affirming care for Black same-gender loving men with HIV. He also is the founder and program director of the Silver Skills Curriculum. He is also co-founder and co-director of PASAN, which is a political and social action network. He also represents County District 2 on the Fulton County HIV/AIDS Care Prevention and Advisory Committee. And so with that, we're going to bring down, and Malcolm's going to talk a little bit about HIV/AIDS trends in the Black gay community. Malcolm, come on down. It's your turn.
Thank you. Thank you. I'm so happy to be here. A little technical check. Am I sharing my screen? Can you guys see my first slide?
Yes.
Okay. All right. So I'm going to bring this into slideshow mode so I can start from the beginning. So yeah. So thank you for the introduction, Larry. Thank you to the Morehouse School of Medicine. I'm really happy to be here. As Larry mentioned, I am the director of programs for Thrive SS, and also I founded the Silver Lining Project, and part of that was the Silver Skills Curriculum. Thrive itself stands for Transforming HIV Resentments into Victories Everlasting. And you know, when you think about Essex Hemphill and wanting to start an organization to save ourselves, to save himself, it's really, really important that I shout out our founders, Larry Scott Walker, Daniel Driffin, and Dwayne Bridges, who were working in public health, who were working in organizations in the community, Aid Atlanta and other organizations. And they realized that, you know what, my brothers aren't getting what they need out of this experience. And so they started Thrive SS. Our mission is to achieve health equity for Black gay men living with HIV. And on this slide, you see Larry and Daniel, but I'll move on to the next slide. So in 2017, the Centers for Disease Control did a study. It was the first of its kind. And the studies, they wanted to know what was the expected lifetime risk of people acquiring HIV. And so, not surprisingly, they saw the numbers were higher in the South. But the real surprise, and the surprise wasn't that it was impacting Black same-gender loving men, Black men who slept with men. It was the impact was so devastating. The report said that 1 out of every 2 Black same-gender loving men would have a lifetime chance of contracting HIV, regardless of geographic location. It didn't matter where they lived, regardless of where they lived in the country, they had a 1 in 2 chance of acquiring HIV. And that was devastating. And when we look at the numbers in Atlanta, in 2020, there were 38,140 people in the Atlanta area living with HIV, 1,254 new diagnoses in the year 2020. And when you think about the year 2020, that was during the pandemic. We look at the percentages, 80%, 80.7% of the people living with HIV, diagnosed with HIV in the metro Atlanta area were male, 71% were Black. That translates to 27,079 Black people in the Atlanta area and 20,500 Black men who sleep with men. And so why are the numbers so high? What is it about Black same-gender loving men that is raising the numbers in our community? You know, you'll hear that, well, we're just more promiscuous than everybody else. You'll hear that, you know, our behaviors are just worse. You'll hear all types of things. We're oversexed, promiscuous. I remember when I was diagnosed with HIV. I've been living with HIV since 1997. And I remember when I was diagnosed, I was like, yeah, I kind of expected it. I knew what I was doing, you know, but the numbers, the data doesn't bear that out. So check this out. In 2017, when they did the study that said that 1 out of 2 Black same-gender loving men would acquire HIV over their life, they also took a look at Black African-American gay and bisexual men that did not have HIV, had they been having sex using condoms in the past 12 months. 17% said no. But then when you looked at all gay and bisexual men that were living without HIV, 16% of them said no. So there's really no difference there. Sexual behaviors among Black, African-American, gay, and bisexual men diagnosed with HIV in the US in 2019, all of the people with HIV that had sex without using any HIV prevention strategy in 12 months, 7%. Of the Black, African-American, gay, and bisexual men with HIV, 6%. So the numbers show that there is not much of a behavioral difference between Black same-gender loving men, Black men who sleep with men, as the rest of the community. So what could it possibly be? What could possibly be driving those numbers? So let's talk about access. Black African-American gay and bisexual men diagnosed in 44 states in 2019, 75% received some care. Only 55% were retained in care, and 62% were virally suppressed. And we see the numbers in our white counterpart, in the white community, were much higher, 85% in some area, in some studies, and a 75% viral suppression rate. And so we have to ask, what is happening here? What can we do? Yes, we have to do better. And how can we do better? So, as we said, I work for an organization called Thrive SS. And as I mentioned, Daniel Driffin, Larry Walker, and Dwayne Bridges wanted to start an organization to save ourselves. They are 3 Black gay men living with HIV. And they came up with a strategy. It's called R3. R3 stands for re-engage, retain, and reduce. Why R3? When they started R3, 19,000 people in Georgia were lost to care. The majority of those people were Black gay men. They were either lost to care because people had moved away, they had lost insurance, but in most cases it was because, they were in care, but they had a bad experience at the doctor's office. There was no trauma-informed care. There was no cultural care. There was nothing to say, hey, what's driving your behavior? What's driving the fact that you can't stay on your medication? What are the problems? They would go to the doctor and the doctor would say, take your pill and you'll be fine. But everybody couldn't be compliant. And so when we looked at R3, we said, you know what? We have to do the work to intentionally capture the individuals who were once actively in care. And we have to bring them back into care with cultural competency, trauma-informed care, and what we call Judy support. As we said, Atlanta is one of has the highest population of Black gay men and has the highest population of Black gay men living with HIV. So if you take the stigma out of it and you make sure that the guys that are living with HIV are talking to themselves, are partnering with themselves, are buddying with themselves. Hey bro, you taking your pills today? You got a doctor's appointment? When you got a doctor's appointment? Can I go to the doctor with you? Oh, you don't understand what the doctor said? Let us help you. That's what we do at Thrive. We have people who will go to the doctor with you, who will talk to you about your results, who will work to keep you in care once you're in care. We identify potential barriers that are hindering our community from accessing the care that they need so that we can thrive while living with HIV. What's the importance of reduction? We focus on keeping people in care, and we focus on reduction because we know that U equals U. Undetectable equals untransmittable. Treatment as prevention. We know that people who are in care, who are taking their medication on a regular basis, are not spreading HIV through sex or through needle or through injection drug use. And so we know that we have a path forward to defeating this disease, but we have to get the people into care and keep them in care. I hear my going off music, so I'll just say one thing. This is why R3 works. We utilize people living with HIV as peer navigators. We love on them. We treat them equally. We let them know of our struggles. We have ambassadors, employees, and members of the community that are R3 trained. We provide 24-hour peer support through our online groups on social media. And we have access to self-love and HIV acceptance programs such as the Silver Lining Project. So I'll stop there and say thank you all very much. Oh, one thing, I can't stop there. I said we had to do better. And I said that 75% of the people were receiving care and 55% were retained in care and 62 are virally suppressed. At Thrive SS, 93% are retained in care. 94% are virally suppressed. So we know R3 works, and we know loving on our members and making sure that they understand that there's no stigma and no shame, and they're not behaving in the wrong way. They're just living their lives as normal men. And that's all there is to it. Thank you all very much.
Mr. Reed, thank you so very, very much. You know, one thing that you said that just really is startling, and that is 1 in 2 Black gay men will get HIV within their lifetime. And that should not have happened. How does it go from the early 80s, from a white gay male disease to now the face and the epicenter of the HIV/AIDS epidemic is Black gay men? We've got a lot of work to do. So thank you so very much, Malcolm. Next, we're going to go ahead and have Mr. Greg Smith. What can I say about Greg Smith? First of all, Greg Smith is a friend, but what stands out most about Greg is he is one of the strongest, one of the, most word that I'm thinking about, he's an advocate that is committed to making changes in the LGBT community. And I want to thank you for that, Greg. Greg Smith is the executive director of Here's to Life, the 25 years working with HIV community and advocating for LGBT same gender loving rights. Here's to Life, which is the organization that he directs, provides substance abuse counseling and education services for trans people, also provides emergency housing. And so Greg is going to come down and talk to us a little bit about the economics of HIV. Greg, come on down here.
Thank you, my brother. I'm honored to be here today. Thank you to yourself and to Morehouse School of Medicine for giving us the opportunity to share about LGBT health in our community. Here's a Life is a program targeting men living with HIV, substance abuse recovery, and transgenders. And we also provide emergency housing. I've been on board now for a little bit over 3 months. But I've been associated with the organization for about 7 years. We are excited about where we're going. And the things that I've learned here in this short period of time has been really helpful in us reshaping the organization to take us to where we want to go. I want to start off first with June 5th, 1981. That was a day that they announced, they wrote this paper that they had this virus. That was the day that lights came on to the gay community like we've never seen before. June 5th, 1981 set us on a path that we never look back at again. But on that day, we realized something, that we were not prepared. On that day, we realized and learned over the next few years the gray in the rainbow. And we learned that the gray in the rainbow was when this disease hit the floor, that Black gay men didn't have access to all of the care, all the resources. Historically, we have been behind in receiving funding and accessing the necessary research. So when I look at and we talk about what can Morehouse School of Medicine do, it's about us now looking at, we cannot repeat the ills of the past. LGBT healthcare to me is 5 different things. It's services for lesbians, services for bisexuals, services for gay men, and services for transgender men and transgender women. They all have different challenges. So when we talk about providing services, we want to provide the services to the 4 groups, to the 5 groups, because when we look at on that day in June, we learned so much that we didn't have an infrastructure. We have now looked at, we've been fighting over the years, we're trying to get Black gay men to become more researchers, trying to get NIH to fund their grants for them to do the research. We've been fighting over the years of trying to develop LGBT clinics. I believe Craig talked about it earlier, about the challenge coming with us just being singled out. When we look at normalizing our healthcare and the trends where we're going, HIV ain't the only thing that's going on in our community. We got LGBT folks living longer and living longer with HIV, but we also too have other challenges when we have families who LGBT folk who don't have family support. So when we look at their healthcare, we want to look at now developing healthcare that's robust. And that's for us, that's the economic aids in, us being involved in this process, us looking at, if you're going to have a healthcare clinic to address the challenges, make sure we have peer navigators in there. So if you're going to be working with transgenders, hire transgenders to be peer navigators, hire transgender men, transgender women to work with individuals. Looking at how we engage them, because a lot of it is really a lot of stigma still attached to coming into healthcare. Also too, looking at us developing LGBT clinics. When we look at a school, a place like Morehouse built itself out of to address the need. And we begin to address the need, we must begin to address the need financially. And so we look at LGBT healthcare. We also want to look at partnering with schools of learning and developing LGBT clinics across the nation, so they can come in. So if you come into your LGBT, it's always not just about HIV. It's about cholesterol. It's about blood pressure. It's about healthy eating. It's those kind of things. And also to normalizing gay researchers, Black gay researchers, advocating for them to get funded to come do the work in our community. Because one of the things with the NIH, they historically have not funded at the level that they should be funded to research the medical needs and mental health needs in the Black gay community. These are challenges that we want to begin to look at. But I've been doing this work now for 30 years. And I remember that day on November 7th, 1991, when everybody's TVs shocked. Was shocked because Magic Johnson tested positive. That shifted the HIV agenda. That shifted because now it looked like heterosexuals. And now it looked like it wasn't just gay folks, because remember that first time during that 1881, it was gay men. That gave us an opportunity to begin to do outreach in the community. I'm working for a Minority AIDS Project. We designed one of the first mobile HIV testing units in the nation. I've worked with AIDS Project Los Angeles. advocating for the policies around us, making sure that we got the adequate resources in communities of color. We had to fight for that. And so we begin to look at now where we're going. We got PrEP, which is a wonderful tool for us to begin to do HIV prevention. But when we look at a place like Morehouse, what do we want them to do? We want them to do things where we don't have to repeat the ills of the past. And so the ills of the past now is in LGBT health. We want to have our clinics. One of the things that I want to go back is when Bishop Carl Bean, who started the Minorities Project, he addressed it because of the gray and the rainbow. And so when we begin to look at now, we have different needs. Black transgenders have different needs than white transgenders. It is what it is because of the economics of where a lot of the Black transgenders have to come from, the journey which they have to take. Also, too, in our health centers, we have to normalize mental health. That's one of the things that's very, very important. Also, too, like for example, here we have our target population as HIV positive men and transgenders. But one of the things that we've had to address in their substance abuse recovery, we have to address sexual addiction. And sexual addiction is not a popular subject matter. So when we talk about health, we can't talk about health and not mental health at the same time if we're going to do LGBT health. And so that really is important for us. But it's a wonderful opportunity now for us to go and do things that we never could do before. And that's, that's pretty much what I got. I'm gonna keep it short because I really want y'all to hear from Will. That's my homeboy.
Thank you so very much, Greg. And the topic that you talked about, expanding this beyond just HIV, but really looking at health needs and healthcare from a more holistic perspective. And I think this panel really, really does that. We've expanded our reach such that we want the LGBT community to be able to enjoy the same health and wellness that other communities enjoy as well. So thank you so much for that. And next, we have an individual, Will Taylor, who is a trans man, all the way from the lovely, wonderful city of Charleston, South Carolina. We just love Charleston. He began his transition at age 22. He is now 46 years old, and he is a professional master barber. And he's going to share with us his lived experience. So without any further ado, I'm ready. Will, come on down.
Hello, everyone. Can you hear me?
Yes, we can.
All
Loud
right.
and clear. Loud and clear.
Thank you for having me. Hope you all are well. So my name is actually Wilhelm Talon with an N. Everybody always sees it and goes R, so I'm not even mad at you. It's, it's Wilhelm. It's German. I'm not, but whatever. Go by Will. So like he said, I started my life in Charleston, South Carolina at the age of 22. I went to my doctor's office and I saw someone else that was transitioning, but it was male to female. And I said, well, Doc, can you explain to me, a little bit ins and outs of this process? And, she was like, you know what, I have no idea where to go with what you would go through in this process. But I do have a colleague that, essentially works with transgender patients. And I said, okay, great. Went to this doctor. I don't know, again, that was a long time ago, what the actual information was back then, because, he started me on testosterone pills. which are very dangerous for an individual because aesthetically you get these results awesome, but it's very harsh to the liver. But again, I don't know that. I'm taking these pills and, aesthetically I'm getting where I want to be. But that's just not, the best course of where I should have been going. So fast forward a little bit, I met some people from Atlanta. And they were like, hey man, you should come to Atlanta and walk a ball. And I was like, oh, I don't, the Cinderella shoes and the, ties and, formal wear, I don't want to do that. And it was like, no, it's not what it is. So they explained it. Anyway, I came to Atlanta and it was so easy to get a job here. I don't remember if you all remember that you used to have classifieds on the PBS channel and early in the morning. So I called one up and she said, well, can you come in and do a job? I said, well, I'm visiting. I wasn't prepared. So she said, well, if you move, come back, see what we have. And I said, wow, it's that easy to get a job. I'm so here. I'm so in Atlanta. Because I used to swear off Atlanta because when AIDS first came out and there was just not a whole lot of information about it, Atlanta had one of the highest rates. And I said, oh no, I'm not going down there because I just didn't know, you didn't know the ins and outs of how you could get it fully until it turned into HIV. So I came and, I got with people in this house and one of my transgender brothers. I was like, well, hey man, where do you get your hormonal treatment? And he was like, oh, I go to Midtown Medical Center. And I was like, okay. So he was like, yeah, come with me. They didn't ask me for anything. They took my blood pressure, weighed me. I gave him $50 and that was it. But on my own, I went to a therapist, to get started on the process here because that's what I had to do in Charleston. So after speaking with her, at the end of it, just talking about childhood and just everything, she just turned around and asked me, how are you sane? And I said, perseverance. I don't know. I've just, had a willingness to live, but I have tried to commit suicide before. But of course, again, like we're talking about mental health, Charleston wasn't really a thing. So I just kept everything inside and just dealt with it. But with that, she just wrote out my papers and didn't, say anything about any further treatment. So going to Midtown Medical Clinic or whatever, it's off and on. You could tell them anything. You could tell them, hey, I'm going to Alaska for 6 months. They'll write your prescription for 6 months and keep it moving. Then they got indicted on some stuff for other insurance practices or whatever. So then now I'm in limbo. I don't know where to go. There aren't any resources. So off and on, my buddy moved away. So he would send me some stuff in the mail, and then when I did finally get a hold of a doctor, and when I tell you the research back then, this was, mid 2000s, there was 6 doctors listed. And of those 6, only 4 were really practicing. So I went to Emory. It took me 6 months to get a actual appointment with this doctor. Once I got the appointment, the insurance that I had for my job wouldn't even cover labs. And I'm just baffled because I'm like, with anything, you have to get labs, So of course that ended because I couldn't afford it. And to fast forward to now, there's a little bit more resources, but it's still pretty much that way. Before I've just gotten insurance within last year, I was going to Grady with the Grady card. And again, it takes months to get in with my doctor. Now I get it. I mean, I know that, you know, you're spread it really thin, but it's just not a lot of resources. Mental health wise, even, you know, your hormone treatment. And I was supposed to actually go to Morehouse for a consultation some months ago, which took, again, months to get. Then after, I don't know, I went on Grady's health site. They was like, okay, your appointment has been canceled. And I'm like, no one contacted me. Like, how is this possible? So I called and they were like, oh, well, you know, the doctor is out on medical leave or whatever. And I'm like, okay, well, I get that. Things happen. And then when it was time for me to go back again, she's no longer with us. We're not accepting new patients. That was it. And I'm like, my gosh, like I've been researching, you know, how to get surgeries and all of this since I was 22. I'm 47. And I see, you know, all of these younger people, you know, come behind me and, you know, especially, you know, that are not of color, just having surgeries left and right, you know, and it's like, I'm sitting here like, what? You know, it's mind-boggling, and it's a lot because, again, somebody that is a lesbian and somebody that is, you know, a transgender male that is transitioning to a male, we don't go through the same struggle. They're not looking in the mirror every day for the same reasons and are not happy with, you know, their extremities. It's a lot. It's a lot to the point of where you do want to take your life. I have constant, you know, situations where that was a thing and I had to even be hospitalized because of it. And the only thing that happened, you know, I went and Grady and they threw me in, you know, with other people, and that was just it. So it's one of these things where there's so many things that need to be addressed when it comes to trans health, you know, but the mental health aspect is definitely at the top. Like, I don't need to just get a paper to be able to get surgery if I have the money. Like, I need to have, you know, the regimen go on to deal with the things that happen beforehand, during, and up to futuristically. And just resources as far as, you know, insurance, you know, surgeries, hormone treatments. I mean, you know, there's not even housing. I mean, in Georgia, like, you, a transgender person can't go into, you know, a homeless shelter. You know, there was a story back some years ago where, you know, this person was not allowed in because they were transgender. And it's like, so what do they do? I don't know. It's a lot. I just hope that we get better and we recognize that there are a lot of differences in this community, and it definitely transfers from each, you know, category. That's all I have.
Thank you, thank you, thank you.
Thank you, Will.
I tell you, this is such an educational experience, you know, not just for the audience, but for us as well. And so thank you for sharing, because it takes a lot to share your personal self with people. But when you do that, they get a sense of connectiveness that we wouldn't otherwise get. So, Will, thank you so very, very much for that and being a part.
Yeah, thank you for having me.
Lastly, we have the wonderful, and I tell you, I just love this lady. And I just want to say, when I leave here and get on the other side and come back again, maybe me and you could do a little something, okay? But Zena is just phenomenal in that she's a strong Black woman who is a tireless advocate for LGBT rights. She is the CEO of Anise Incorporated. Her name's spelled backwards, by the way. It's an HIV/AIDS and mental health advocacy agency. And even more than that, she holds a master's level degree in social work, master's in addiction counseling, clinically certified human trafficking victim service provider, and clinically certified sex offender treatment specialist from the National Association of Forensic Counselors. So today, Zena serves as an expert and advocate for mental health, substance use disorder, holistic harm reduction, HIV/AIDS intervention and risk reduction, family trauma and transphobia/homophobia in the Black LGBT community. And Zena's going to talk to us a little bit about the B in LGBTQ+, bisexuality, that she feels does not get the deserved attention that it should. So Zena, come on down here.
Here I am. Hi, everyone. Of course, I want to thank Morehouse School of Medicine for allowing us to actually talk about this issue that's really affecting the African-American community. So you see my first slide is related to demonizing bisexuality in the African-American community. When I go into details, I'm going to talk specifically about why I feel that it's kind of demonized in the invisible population. So you could go to the next slide. The next slide is just basically saying who I am. You could go to the next slide. When we talk about what is bisexuality, next slide, please. So when we go into bisexuality, we clearly see where we say bisexuality is used to describe persons who have experienced emotional, romantic, and sexually attracted engaged to the same person, the same sexuality, the same person, like male have I'm sorry, I'm nervous and I do not know why. Where you have sexual relationships to both male and female genders. Next slide, please. So when we look at bisexuality, and when I looked at CDC in 2016, it clearly showed that 1.3% of the women identified and 1.9% of the men identified as homosexuality, gay or lesbian. And then 5.5% of the women and 2% of the men said that they were bisexual. So when you look at this, you clearly see that almost half of the population have been identified as bisexuality related to men and women. Next slide. So when I talk about the heteronormality, so what happened is when I go into that, it seems that a lot of times that when we talk about the GLBTQ population, that the heterosexual population is really kind of demonizing homosexuality, where they feel that it's just based on a male and a female. They're not looking at the perspective where it's related to bisexuality, sexual identity, and gender roots. When we talk about that, we really need to go into how the benefits of someone actually being straight and the privileges of being a straight person when we talk about heterosexual individuals. Heterosexual individuals do not have to deal with the secrecy, shame, and guilt as it relates to their sexual preference or their sexual identity. There's some of the things that homosexual individuals have to go through. So when we talk about, when we're dealing with the LGBTQ population, we really need to focus on the secrecy, shame, and guilt as it relates to being homosexual, bisexual, or gay. Next slide, please. So basically, what is homosexuality? Homophobia is basically fear, hatred, discomfort, or mistrust of people who are gay, lesbian, or bisexual. Biphobia hate actually talks about, when I go into bisexuality, bisexuality is hated a lot. Well, I don't want to say hated, it's just overlooked, specifically in the heterosexual population, in the bisexual population, in the homosexual population. So when I go into this, I see that a lot of people do not identify as being bisexual. Over the past 10 years, I have been wanting to be like the bisexuality poster child. I clearly see that when someone needs someone to speak about bisexuality, they always call on me. You know, I see that because a lot of people are not identifying that they're bisexual. A lot of people are not identifying that they're bisexual because of the stigma where they feel that we are greedy and then they feel that we are confused. So we kind of see the homophobic as it relates to the straight population and also in the gay population. Next slide. So when I talk about the reason why I want to talk about health disparities, because we really see the health disparities really affecting the bisexuality population. We suffer more mental health than heterosexual, lesbian, and gay population. And the reason why I say that is because they don't have that many studies when we're talking about bisexuality. We're really starting to talk about bisexuality a lot when we're talking about the Black gay population, the Black men, but we are not really here to really talk about bisexuality as it relates to women or how bisexuality is actually really affecting HIV and AIDS, specifically in the African-American population. So these are some of the outcomes when we look at high rates of anxiety, depression, mood disorders, reporting self-harm, suicidal thoughts, suicide attempts, low levels of social support. So when one of the things when I talk about low levels of social support, once again, we do not have a lot of people who are clearly identifying that they are bisexual. We have people that are identifying that they're gay. We have people that are identifying that they're transgenders. We have people that are identifying that they're gay, but we don't have that many people identifying that they are bisexual. So when you look at the first one, the first statistics that shows that half of the people that are in this GLBT population are bisexual. But what happened is we don't identify as bisexuality because the stigma, like I said, on both genders, with the straight population and with the bisexual population. And the rates are really high when we talk about substance abuse, including cigarettes and heavy smoking. And one of the things that I see is that a lot of times bisexuality, when I talk about that, we are the invisible population. And being an invisible population, that means invisible data, invisible support, and invisible advocacy. Next slide. So when I talk about, again, biphobia, when we talk about biphobia, we talk about the stereotypes, right? So when we talk about the stereotypes, I talk about greedy, I talk about promiscuous, I talk about sexual STIs. They say that bisexuality individuals are untrustworthy. Bisexuality only seek sexual attention from heterosexual men, which is not true. That bisexuality men are too afraid to come out, therefore really consider themselves as gay. So one of the things that when I talk about bisexuality and the stereotypes, I know that when I got married in 1990, I knew then that I had tendencies of being bisexual. So what happened when I got into that world, one of the things that they were telling me was that you're not bisexual. And I'm like, how are you gonna tell me I'm not bisexual? You know, I know what I am. It's like you're gay and you think you're bisexual. So a lot of times that I really was identifying myself as a lesbian. I started dressing real hard. I started dressing to implement, to talk about me being, being lesbian, because I wasn't really identified as bisexuality in this population. So as I got older, I realized that I am bisexual. I am attracted to men and I am attracted to women. So when I was comfortable enough to say that, that's when I really wanted to advocate. And when I started doing Anise Incorporated in 1996, I clearly saw that bisexuality and how I was able to connect the bisexuality to specifically how the virus is spreading with African-American women. So I wanted to make sure when we talk about bisexuality that it was included, that we actually talk about bisexuality when we do reports. We talk about bisexuality where we could get rid of the stigma. When we talk about bisexuality where it's not an invisible population. So I want to connect bisexuality. I love that we are connecting bisexuality to Black gay men, but we also need to connect bisexuality to women in general, because there are women that are bisexual. Next slide. So this is, I don't know if people are going to get offended or what, but the reason why I actually put this side in place, and I think that these, where we talk about fluid, where we talk about pansexual, where we talk about queer, and all the other items, we want to make sure that these things, I feel that a lot of things are coming to play is because we are not really embracing bisexuality. So I feel that all these things that we are actually talking about could fall under bisexuality, where we can make it inclusive, where we could just really have it where we are talking about bisexuality, because bisexuality, again, is 50% of the population. Next slide. So this is the difference. So when we talk about the difference between these two sexuality, pansexuality is more when you are attracted to someone's spirit, where you don't care if they're actually male or female. When we talk about the other sexuality, this is where we don't care if they're male or female, but we're actually looking at if it's we don't care related to their spirit, but we are focusing on if they are a male or female. But those are the only two differences. But again, I really feel that this could be the subcategory related to the bisexuality. So my goal is to actually allow people to be themselves, to allow them to be comfortable who they are, to get rid of the secrecy, shame, and guilt, so we can start dealing with services as it relates to who they are and how they're identifying themselves. Next slide.
Zena, we got half
So
a
when
minute.
I talk, okay, so when I talk about that, I really want us to focus on the articles with the human rights, and it would be Article 1, 2, and 3 that really allow people to be themselves. So I really want to focus on a lot when we talk about bisexuality, because we realize that bisexuality is an individual population that we really need to talk about in the GLBT community. And those are my resources. Thank you very much.
Thank you so very much, Zena. And I tell you, each one of you that has presented today really has increased my knowledge and awareness, and particularly when we make sure that we include all elements when we talk about LGBTQ. So thank you for providing that. So we're going to take the next 15 minutes or so, and we're going to see what questions the audience has. And while Corey or either Kanisha are looking at questions in the chat for the panel, I'd like to pose a question. I want to make sure we get this question before we end. And just, one person can answer this. But it's what we call the magic wand question. And that is, if you had all of the resources at your disposal, what strategies or recommendations would you have in addressing the needs in the LGBT community? So you got all the resources, you got this magic wand. What would you do? Somebody come down and answer that. Is that you, Greg?
No, it wasn't me, but I'll give it a shot.
Okay.
Having that, I would just say replicating our model, making it so convenient for people to access services. To me, that's what we do with our money. And then I'm about convenience. So that's pretty much me.
Thank you. Anybody else want to take that on?
Larry, I would thank you for the question. I think it's a great question. It just opens the door. I spoke earlier to the need to recognize that, particularly as Black LGBTQIA people, that we are a people, and that's important. We're at a state because of some of the issues that were mentioned, whether it was the economic marginalization that Greg spoke to, the biphobia, which is connected to homophobia and transphobia, our erasure, that we have to assert the legitimacy of our lives. We have to assert that our lives matter as well. To that end, I would enforce having physical space, having a network of centers, spaces, physical space where a Black trans man who's 18, a 70-year-old Black lesbian can go and not only connect and experience community outside of their private circles, but also can learn about history and culture. We have so much history that is rarely curated and taught, and it is precious. So I would have a network of cultural education history centers that are not, as opposed to, I think it's important to have, of course, all kinds of services to meet unmet needs. I think that what we see playing out is a lack of affirmation and acceptance. And so we have to be the ones to provide that for ourselves. So that's what I would say.
Thank you so much. Is there any questions in the chat, Kanisha or Corey?
And while we're waiting, Lawrence, what I would say is, if I had unlimited resources, I would harness the power of the media in ways that, you know, that we sell, you know, that we sell sneakers, that we sell, you know, we have so many things that are distracting in the media. But how do we harness the media so that we do achieve what Craig just talked about, and what Greg just talked about, and what Zena was talking about, and Will, to make people understand our lives? As I, you know, before we started this conversation, before all the folks joined in, you know, I was talking about Tori Cooper and how Tori Cooper, we had a session with her yesterday, and Tori was talking about her transition. And she talked about being a trans woman. Well, one thing she said was, she said, I didn't transition to be a trans woman. I transitioned to be a woman, right? And that was one thing. And then, but then she talked about her transition in a way that made us realize that, you know what? We're all trans, because we've all transitioned from one thing to another. It's called growth, right? It's called growth, and it's called change. And I wish that I had the resources to blast through the media that I'm a Black man, I'm a gay Black man, I'm a successful Black man, and you know what? I love my mother, I love my father, I love my brothers and sisters just like you do. I am not trying to turn your children gay and all of this other, just something to fight all of the negative stereotypes that are out there. If we can have a media system that makes 71% of a political party believe a lie, we should be able to do, you know, we should be able to get people to believe the truth. So I'll just leave it there.
Thank you so very much. Very interesting quote in the chat by Ashley Jones, and she says, "Thank you, Will. I struggle with my feminine body, and I have been so scared to accept that I am transgender. Thank you for your visibility and your wisdom." And so until we get more questions in the chat, here's what I'd like to also ask.
We have a question in the chat, Dr.
Okay.
Bryant, from Will. First, he says, so much rich information. It would be incredible if some or all of the presenters would share their slide decks. And then it goes on to say, what are your thoughts on the possibility that PrEP can be used for prevention and the possibility of foster unprotected sex? It's occurred to me that it might contribute to the 1 in 2 contracting HIV in our lifetime.
Okay, who would like to take that on?
So let me jump in here. So a couple of things. So PrEP is used to prevent HIV. There was a thought when we first started talking about PrEP. And first of all, let me just say this: PrEP has been around since 2012, but unfortunately, the PrEP in our community, the uptick of PrEP didn't really start until 2017. But PrEP is used as a preventative for HIV. So when you think about getting people into care who are living with HIV, and U equals U, as I mentioned, you have, undetectable equals untransmittable. So people who are living with HIV are not spreading the disease. And then you have people who are may have a partner who is living with HIV, who is trying to prevent themselves from contracting HIV, they may be on PrEP, or someone who is, has condomless sex and, they want to prevent themselves from getting HIV. And we thought that, a lot of people thought that when PrEP first came out that, okay, people are going to worry about not getting HIV and they're going to have condomless sex and they're going to get other STIs. Have we seen an uptick in STIs? Yes, but is it due to PrEP? No. The studies, all the information out there is that people just don't like condoms. People were having condomless sex before PrEP, after PrEP, during PrEP, and we have not seen an uptick in condomless sex. And so, we've got all kinds of studies that are showing that, that is just not the case. But there is still information. We still have to get information out. We here at Thrive, yes, we're here to, stop the spread of HIV. But as I mentioned, our mission is to improve health equity among Black gay men, and health equity includes STI information. Just making sure that people have all the information to enjoy sex. We can be sex positive, we can enjoy sex, but we can be careful, we can be safe, and not just from HIV, but from all the other STIs that are out there. So thank you for the question.
Hey, I wanna, when PrEP came about, because Anissa has a PrEP clinic, and one of the things that we are struggling with is to get African-American women on PrEP. We are struggling. I mean, struggling. So if I had $1 billion or $1 trillion, I would do the marketing campaign for African-American women in general as it relates to PrEP. We are giving $20 Victoria's Secret cards. We are doing everything we need to do to try to get women on PrEP. One of the things that we were able to, we are working on, we work with a lot of women that are sex workers and active ID drug users, where we are attempting to get them on PrEP. But my goal is to get bisexual or heterosexual women on PrEP, but the media is not promoting it for women in general. So we are advocating. I think that this would help domestic violence. This would help a lot of other social determinants of health if we actually do some marketing where we can get women on PrEP.
Thank you, Zena, for that. And before the next question from the audience, I'd like to pose this question to someone on the panel. All too often, we talk about the problems associated with the LGBT Black community, but I want someone to speak to the strengths. I want someone to speak to the successes. What makes our community thrive, and what makes our community a significant contributor to the overall community? Anybody can take that question.
So I know Craig is going to say a lot about this, but I got to jump in before he does. So maybe I'll just introduce him, okay? Because I know Craig is going to go off on this. But when we want to talk about the successes, I will be celebrating my 25th anniversary with my husband in September. I live in Atlanta, Georgia. I am a gay man. I am a Black gay man living in Atlanta, Georgia, who has been in a committed relationship for 25 years. Okay, Craig, you can go ahead now.
Thank you, Malcolm. That's a wonderful question because so often we are considered by our challenges, defined AIDS among them, right? Our challenges and deficits and struggles. I would say several presenters spoke to this, and that is the bonds that we create. I spoke to them as either, social circles or friendship circles, but our creative families. That is an organic invention that we came up with in terms of, and what I mean by that is investing the level of mutual support and reliance on friendship circles. The ball community, house ball community is such an important a sterling example of that organic infrastructure. It is genius. It is genius. It is no more or less flawed than any example. Because it's often, again, with marginalized people, our stuff tends to be stereotyped. That being said, there's such strength in that community, again, in terms of having, people's roles being defined as support, and people being directed beyond the performance, to make sure that people are housed, are fed, are encouraged, and that we do that on an organic level and in an intergenerational level. I think it is our leadership. We don't get enough credit for our role in responding to, now as we're responding here, these presenters, but responding to HIV, the early years. What you spoke to, Greg, about that June 5th, 1981. We have always been in the battle. And at times we have been selfless. We helped teach the world about safer sex when we had a president that couldn't even mention the word AIDS. There was very little money or movement among the federal and local governments for white gay men, much less so what that meant for us as Black LGBTQ. Nevertheless, we rose to the occasion before we had CDC grants to write for, before we had Ryan White. We were out there, whether or not we called it buddy systems or not. We were there. I would say, lastly, it's just the overall expression, our contribution to culture and language. We are innovative people at the core of innovative people. And sometimes our relationship with Black community at large is strained. That's some work. There is a reconciliation that needs to happen in Black community. Let me just do a quick, I'm trying to wrap this up. I have no belief that, and I've never seen the research that confirms that Black people are any more homophobic than white folks. But that's a way in which I think Black people are stereotyped. Nevertheless, we have to deal with the way that we oppress our own within our own community. So, and we have tried to a certain extent, to teach our people, to challenge our people, our Black heterosexual kinfolk. And that yet is another example of our brilliance. So I'll leave it at that.
Thank you. Thank you so much. Listen, we've got to wrap this up, but this has been nothing short of phenomenal. The movers and shakers and the leaders, the panel, you've been a very distinguished panel, and I've learned so much from your wisdom. And so again, I personally, and this is the best birthday gift I could have had. I wanted to do this on my birthday, and so my soul is satisfied. And so the last minute that we have, we want to turn it back over to Morehouse. But here's what I want to leave you with, a quote by Alice Walker. And she says, "I think it pisses God off if you walk past the color purple in a field somewhere and don't notice it." And I really, really feel like that exemplifies the Black gay community, because we bring a multitude of talents, of strengths, of values to our overall culture. This culture would never be what it is today. Diana Ross would never be who she is. Aretha Franklin would never be who she is, were it not for our community. So with that, thank you.